In this presentation, we shall be looking at meniscal tears within the knee joint. The meniscus is a fibrocartilaginous structure that lies within the knee joint, and we have two of them. One is on the medial side and one is on the lateral side, and they play a very important role within our knee joint. They lie between the tibia and the femur, and they are the most common reason when injured for arthroscopic procedures of the knee to be performed. Of the two, the medial meniscus is more frequently torn than the lateral meniscus, and that is because it is a less mobile structure due to its attachments within the knee joint. Often, people who sustain a meniscal injury state that it was at the time when they had a twisting type of injury to their knee. When this twisting injury occurs, often people complain of pain at the time, but there is no swelling, unlike other injuries of the knee where you get swelling straight away. In meniscal injuries of the knee, the swelling often is delayed and may happen later on that day or a few hours later. When you see the patient, they may be complaining of pain within the joint. They may be experiencing some catching, some popping, or some locking, terms that patients use to describe their symptoms. Patients may find that their knee is giving way, and the reason for this giving way may be due to the fact that the meniscus is injured, and the meniscus is a secondary stabilizer of the knee, or it may be secondary to pain, and that's why they're giving way. Patients may also complain that they're getting recurrent effusions of their knee. In some patients who have much larger tears of their meniscus, then they may well present with a locked knee. Once you've taken your history and identified the symptoms that the patient is experiencing, you then move on to your examination. And when you're examining the knee, you may find that the patient has a locked knee. You may find that patient experiences pain when you palpate along their joint line, and there may also be presence of an effusion within the knee. Now, you can also conduct a McMurray's test, and if the McMurray's test proves to be painful, then this may raise your index of suspicion that this patient has a meniscal tear. And as previously mentioned, in patients who have very large tears of the meniscus, they may well not be able to fully extend their knee joint and may demonstrate some locking to you in your examination as well. Once you've done your history and examination, then imaging would be your next port of call, and an MRI would be the gold standard investigation in order to diagnose the presence of a suspected meniscal tear, and it will also allow you to identify any other injuries that may have occurred at the time of the meniscal tear. Your options of management for meniscal tears can be divided into non-operative and operative treatments. Within the non-operative arm, there is conservative and medical management. Conservative management involves patient education, modification of their lifestyle, and physiotherapy. You may also choose to go down the medical management route, which is really designed to help the patient manage their pain. And you can use oral analgesics for this, such as paracetamol and non-steroidal anti-inflammatory drugs, or an intra-articular injection of steroid and local anesthetic into the affected knee may provide them with adequate relief. If a decision is taken to go down the operative management, and this would be based on the symptoms that the patient is experiencing, then your options are to either debride and remove the torn part of the meniscus by way of an arthroscopic partial meniscectomy, or to try and repair the meniscus, again doing this arthroscopically. A decision to repair the meniscus is dependent upon the location of the tear within the meniscus, the configuration of the tear, and also any other pathology that may well be within the knee, as well as the age of the patient.